Good afternoon to all the doctors from the medical world gathered here today for iamicon 2021. I, Abhishek Kapila, the head of iamicon, would like to welcome you to the 9th edition of Indravadan Ambalal Modi Innovation Conclave, or as we call it, iamicon. We are happy and honored to bring you India's largest virtual science and innovation conclave. Your presence has certainly enriched and elevated the stature of this conclave. I now welcome Mr. Ashok Singh, General Manager of Cadila Pharmaceuticals. Mr. Ashok Singh looks after the Magnastar division of Cadila. Over to you, sir.
So, good morning all. We feel privileged to be amongst people who have attained great name, fame and success through their path-breaking work in their respective field. Your presence actually has taken the stature of this iamicon 2021 to a great height, have faced many notch-up. On behalf of this iamicon team, I'd like to thank each one of you for your esteemed presence at this occasion. So let us come together and salute the spirit of innovations with iamicon anthem and the film. Can we have the anthem, please?
हौसला सुनने में तो एक आम सा 3 अक्षरों वाला शब्द है, लेकिन ये शब्द इस दुनिया की तस्वीर बदलने की ताकत रखता है। जन आंदोलनों से लेकर कोरोना महामारी तक जब जब इस देश को परेशानियों ने घेरा है, तब तब यहाँ के लोगों ने एक दूसरे को हौसला देकर एक बेहतर कल की तरफ कदम बढ़ाए हैं। चाहे वो राजनीति हो, खेल का मैदान हो या विज्ञान की नवीनताएं, इस देश ने कई ऐसे व्यक्तित्व देखे हैं जिन्होंने अपने जज्बे और हौसलों से बड़े बड़े मुकाम हासिल किए हैं। ऐसे ही एक महान शख्सियत थे कैडिला फार्मास्यूटिकल्स के संस्थापक श्री इंद्रवदन अंबालाल मोदी। उनके नेतृत्व और हौसलों की बदौलत ही आज कैडिला का नाम इस देश के कुछ सबसे आधुनिक दवा निर्माताओं में शुमार है और यहाँ निर्मित दवाएं इस दुनिया के हर कोने में जिंदगियां बचा रही हैं। श्री इंद्रवदन अंबालाल मोदी के व्यक्तित्व और उनके हौसलों को जीवित रखने के लिए कैडिला परिवार की एक पहल है, जिसकी शुरुआत 9 साल पहले हुई थी। इस मंच के द्वारा हम उन व्यक्तियों को सम्मानित करते हैं जिनके हौसलों ने इस दुनिया की सूरत बदलने की हिम्मत की है।
उम्मीदों की भरकर गठरी युवक एक निकला था घर से, बस सच्चाई और मेहनत की ताकत उस गठरी में भर के ये ठानी थी उसने मन में कि राह अलग सी चुननी है। विज्ञान ज्ञान को जोड़े जो एक ऐसी माला बुननी है।
ये सीख आपसे पाई तब के इसी राह पर चलना तुम, नई सोच और उल्लास का नारा हर एक दिशा में भरना तुम।
फिर सींचा हमने एक सपना और उत्सव का आरंभ किया। बदलाव की वाणी बोले जो उस पहल का तब प्रारंभ किया। दुनिया भर के सबसे उम्दा ज्ञान का होता हो जमघट, जो स्वस्थ विश्व के सपने की पहचान सा लगता हो हरदम। जहाँ नए नए संशोधन को सम्मान मान हर छोर मिले। विज्ञान की अनुपम खोजों पर संवाद जहाँ हर ओर चले। हर शहर पे छाया है अब इस उत्सव का एक रंग, तो चलो सभी जुड़ जाएं अब iamicon के संग। की ऊर्जा सदा बहे, आगाज हमें ये करना है। चाहे, इस लक्ष्य को हासिल करना है।
इस सोच के अविरत उत्सव यशों में करना है, देश के कोने कोने तक अपना परचम अब धरना है।
इस लहर का थामे दामन अब हर एक से वादा करना है, खुशहाल जिंदगी के पथ पर एक साथ हमें अब चलना है।
अब देश का हर जन चाहे कि रंग जाए इस रंग,
अब देश का हर जन चाहे कि रंग जाए इस रंग, और चलो सभी जुड़ जाए, अब आया है माइकॉन के संग। आया है माइकॉन के संग,
आया माइकॉन,
आया माइकॉन, आया माइकॉन के संग।
Gentlemen, there are a lot of ladies and gentlemen, there are a lot of interesting sessions lined up for you. Among us today, we have respected national and international speakers. We'll also have panel discussions to ensure more interaction and basically the inclusion of diverse topics and opinions. The panel of experts from the field of specialty medicines. I will now invite our president, Mr. Suresh Gupta, our beloved president, to take up the dais shortly to bring out the real flavor of this conclave, iamicon. Once again, welcome to the iamicon 2021. Enjoy the conclave. Over to our beloved president, Mr. Suresh Gupta.
Namaskar. It gives me immense pleasure in welcoming you all to the 9th edition of Indrabadan Ambalal Modi Innovation Conclave, which is now popularly known as iamicon. iamicon was instituted in the memory of our dear founder chairman sir, Shri Indrabadan Ambalal Modi ji in the year 2013, which started in a very small, humble way with 33 cities to begin with, which has now expanded to as many as 151 cities across India, including Nepal. In fact, iamicon has now become international by going to as many as more than 10 countries across in the world. iamicon is based on the theme of science and innovation. And our founder chairman, sir, had the core values in research and innovation. And I'm very happy and very proud to inform you that in our company, we have been able to give, through science and innovation, first of its kind products in the world, like Polycap, Mycidac, Rizorin, Cadiflu, and now very lately, Sepsivac, which, as you know, during the COVID times, has been able to save many lives. iamicon has also instituted an award system for the brilliant minds in the medical society known as Indrabadan Ambalal Medical Excellence Award, by which we recognize the best talents in the medical field and award them with a gold medal. iamicon has been based also on the theme of spreading science and innovation and knowledge across the medical fraternity. I'm very, very sure that through various events which we had during the last 9 years, we have been successful in spreading the science and knowledge. And I'm also sure in the 2021 event of iamicon 2021, the same effort will be spread across. And I would like to thank all the medical fraternity, all the medical doctors, all our panel speakers from India and international to put an effort together in this direction. From last year, when the COVID happened, iamicon became digital. And this is the second version of that. And I'm very happy to share with you that at this point of time while I'm talking to you, nearly as many as more than 30,000 doctors across India and maybe international are actually watching this event and becoming a part of the iamicon. I would like to thank all of them for becoming a part of this and making a success out of this. I would also like to thank once again all the panel members from India and from international who have come and are participating in making our event a success. With this, I would like to take this opportunity to wish a great success to iamicon 2021 and like to thank you all for this. Thank you very much.
Thank you, our beloved President Gupta sir, for highlighting the core ethos of Cadila. Like Suresh sir rightly said, all our efforts and our focus to keep bringing more innovative solutions to the biggest challenge in healthcare continues. On this note, I'd like to showcase a short clip on our first in the world medical innovations. Can we have innovation AV, please?
There's a reason why we do what we do. And it's not just the desire to grow more. What drives us is this little thing in our core. That little thing is called hope. The hope in our core drives us to seek out better futures. It pushes us to innovate our present for a safer and healthier future. Every time we took the lead and invented the treatment for something once considered untreatable, it was because we don't believe in waiting for the future. We believe in innovating and creating it. All this is because our hope for a better world pushes us to. We don't believe in just talking, we walk the talk. Polycap, world's first 5-in-1 polypill for primary and secondary prevention of CVD. Cadiflu S, India's first influenza vaccine for virus-like particle and nanotechnology. Mycidex C, the first active immunotherapy for lung cancer. Rizorin, world's first booster rifampicin for treatment of tuberculosis. TH rabies, world's first novel 3-dose rabies G protein vaccine using virus-like particle VLPS technology. And Sepsivac, novel immunomodulatory therapy for the treatment of gram-negative sepsis. Sepsivac offered 11% absolute reduction and a 55.5% relative reduction in mortality in patients of gram-negative sepsis. Our innovative drug, Sepsivac as an immunomodulator in sepsis, was found to boost the innate immune response and increase resistance against the progress of COVID-19. And it is because of the determination of over 9,000 people from over 100 countries that we have been able to achieve what others thought was impossible. Cadila Pharmaceuticals, driven by the passion to transform the present and future.
Well, we are going to unfold our first session. The topic is vitamin D status during pregnancy and its impact on birth outcome. To discuss this, we have with us galaxy of leaders, thought leaders across the country and the world. In fact, they are the institutions and authority among their respective fields. Can we have their intro, Abhi, please?
Dr. Rishi Shukla. He is the head of the Department of Endocrinology at Regency Hospital Limited, Kanpur, and Chief Consultant at Center for Diabetes and Endocrine Diseases, Kanpur. He has presented at several international and national conferences. His current published work on COVID-19 are as follows. His area of interests include diabetes education and social issues and type 1DM. He was invited as faculty in European Association for the Study of Diabetes, International Society for Pediatric and Adolescent Diabetes, and various other national organizations. He is a member of ESI RSSDI Recommendation 2020. He is running regular patient education program for the last 26 years by the organization Society for Prevention and Awareness of Diabetes in Kanpur. He was the first one to organize education programs on type 2 DM. Professor Abdul Hamid Zargar. He is a member of High-Powered Committee on Health and Medical Education, Government of India. He is the Economic Times Awardee for the year 2021. He was the former director of Sher-e-Kashmir Institute of Medical Sciences, Srinagar. He was also the chairman of Department of Endocrinology. He was a member, Institute Body at AIIMS, New Delhi. Dr. Abdul was a member of Medical Council of India. He was past president of Endocrine Society of India and editor-in-chief of Indian Journal on Endocrinology. He has authored over 200 publications in national and international journals. The organizing committee of iamicon welcomes Professor Bruce W. Hollis. Dr. Bruce did his BSc and MSc from the Ohio State University in 1973 and 1976 respectively. In 1979, he received a PhD in nutritional biochemistry from the University of Guelph, Ontario, Canada. From 1979 to 1982, he completed a fellowship in endocrinology in the Department of Medicine at Case Western University. He subsequently joined the university as the faculty in the Department of Nutrition. In 1986, he became an associate professor at the Department of Pediatrics at the Medical University of South Carolina. He was then promoted to full professor of pediatrics, biochemistry, and molecular biology in 1994. In 2005, he became the director of pediatric nutritional sciences. Dr. Bruce has published over 300 peer-reviewed articles with nearly 57,000 citations. His scientific achievements include both basic and clinically based research. He has done exemplary work in developing techniques to measure vitamin D compounds in biological matrices. Using these techniques, he defined the vitamin D content of human milk as well as many facets of vitamin D metabolism. In the latter part of his career, he undertook clinical projects to determine the vitamin D requirements during pregnancy and lactation, as well as defining the relationship of vitamin D in neoplastic susceptibility and treatment. His studies with respect to pregnancy and lactation have resulted in a change in clinical practice with vitamin D's ability to decrease complications of birth for the mother as well as preventing preterm birth of the child.
May I request Dr. Rishi Shukla to take this event forward. Over to Dr. Rishi Shukla.
Muted. Rishi, muted.
You need to unmute, sir.
Thank you, Mr. A.K. Singh. Thank you, Cardiology Pharmaceutical. Thank you, Mr. Abhishek, Suresh Gupta ji. And good afternoon to all my friends, seniors, contemporary, younger friends. Always been pleasure. So it would be a nice afternoon. Must be very nice for Professor Zargar, who is sitting in Kashmir enjoying the absolutely nice weather there. Coming to vitamin D, I think as an endocrinologist, what I first understood about this molecule is it is the steroid hormone. And then in last 15 years, so much has come into it. And as a spiritual person, I'll call it as a mystic hormone. Its role from permissive to therapeutic entity. But one thing for sure, most of our country is vitamin D deficient, and it has a role in almost all aspects of metabolic diseases. I think with this small comment, I hand over this to our respected chairperson and my elder brother, Professor Jargar. Jargar sir, please.
Thank you so much, and Dr. Rishi and Mr. Ashok Singh. It's really a pleasure. I'm being associated with this iamicon 2021, particularly realizing that one, I am meeting some of my lifetime friends, and 30,000 people are listening to us, as Mr. Suri did tell us. Vitamin D and polycystic ovarian syndrome are the two disorders that have been extensively talked about in the last 2 decades. Rishi, I grew up in endocrinology talking about iodine deficiency and trying to eradicate it. And in my mature years, I seem to be handling the vitamin D deficiency epidemic. So it's a huge transition that if we took care of one epidemic, are we good enough to create awareness about another epidemic and handle it well? And this whole process started with some of the work that we initiated a couple of decades back in the country. I think we have a very wonderful topic that we have been talking about for quite some time. One, giving mother as good a vitamin D status as possible so that her health remains perfect, and pregnancy-related outcomes, which had been talked about getting abnormal if there's a vitamin deficiency, getting back to normal, and giving an additional advantage to the fetus to be exposed to an adequate amount of vitamin D. And to what extent we have understood all that, and to what extent we have succeeded in translating that understanding into the real world, I think today Cadila has asked a master in the field, Professor Bruce Hollis from Ohio, to talk about the topic of vitamin D status during pregnancy and its impact on birth outcomes. I think without wasting much time, we should straightway go to Professor Bruce Hollis's talk, and then we see what new things emerge from there. Then Rishi and me would discuss it, and if there are any questions, inquiries, they'll be discussed and talked about. Over to Professor Hollis.
Thank you very much for having me present this data that we've worked on for many years. I'm going to talk about vitamin D status during pregnancy and its impact on birth outcomes. Next slide, please. This is an overall slide of the general metabolism of vitamin D. Vitamin D occurs in several forms. It's transformed in the body. And what we have here is in the far left top, we have the parent compound that I call vitamin D. It's the form that is made in the human body when you're exposed to the sun, or what you take in orally from vitamin D supplementation. And that form of vitamin D doesn't stay in the blood very long. The half-life is only about 24 hours. And it's widely distributed in the body to different organs. The most important one is the liver, where it's then transformed into another vitamin D compound. It's the prohormone, or the intermediate form that circulates for extended period of times in the body, and that's 25-hydroxyvitamin D3. Now, vitamin D acts, and then the prohormone is ultimately metabolized into an active compound, which is 1,25-dihydroxyvitamin D. And the half-life of that compound is very short. It's only hours. And that is the active hormonal form. It's one of the most potent steroid hormones in the body, and it's involved in a number of different gene actions, both repressive and supportive. And it acts, everybody's familiar with how vitamin D acts in an endocrine function in maintaining serum calcium through kidneys, through parathyroid hormone. We've known about that for a long time. What we haven't studied in great detail is the paracrine endocrine function, which is a big yellow circle And that's where 25-hydroxy or vitamin D, either one, can diffuse into a given cell that contains a 25-hydroxylase and or a 1-hydroxylase, and can convert those compounds into the active form of 125 for what we call autocrine function, where the cell where it's produced uses that compound. And when we're talking about these things in pregnancy, this is primarily what we're talking about. We're talking about this autocrine function more than we are the classic endocrine function of vitamin D. And the other important thing here is when you go to your physician and you want to know what your vitamin D status, if you have enough vitamin D in your circulation, you want them to measure the prohormone, 25-hydroxy vitamin D form. It's very important that you understand that that's the one that you want to measure to know appropriate vitamin D status. Next slide. We all know what happens when you have too little vitamin D. This has been known for a century. And what happens is too low vitamin D results in rickets, as you see in this child. Profound rickets, you can see the bowed legs from lack of vitamin D. And the good news is that you can correct this. The same patient here on the right, when she was given vitamin D, you can see her legs are fixed. So and this is the endocrine function of vitamin D, maintenance of serum calcium and bone health. And while you can correct this endocrine function, I'm not so sure the same deprivation of vitamin D doesn't cause long-term effects in any patient, be it a pregnant patient or a child or anybody else. And because it's so involved in cellular homeostasis. So just because it can correct this particular malady doesn't necessarily mean the same thing would happen in other things that vitamin D is involved in. Next slide. Next slide. Here's another example of rickets, although this is not the classic. This is called the craniotabes. You can see the depression in the skull where the fontanelles don't fuse properly. This happens in utero, and this is really a profound deficiency. And this is seen in vitamin D deficiency during pregnancy. And while again, you can see the bone structure that's not normal, there are other functions in pregnancy and vitamin D that you can't see. This was published several years ago out of Japan. You can see the publication. And this is, and again, vitamin D supplementation post-birth will correct this malady. So you can correct this, but it's still an indicator of vitamin D deficiency during pregnancy in the mother. Next slide, please. Next slide. This slide is a great illustration. It's very old data, but it shows how the data early on was not interpreted in an appropriate manner. This data, it was from 1971, and Dr. Haddad had developed a method to measure 25-hydroxy. Up to this point, we couldn't really measure vitamin D status. So this assay was developed, and they went and collected samples from, as you see in the group, there are normal volunteers, biliary cirrhosis patients, which are lipid malabsorption patients. And they chose those patients because lipid malabsorption vitamin D is lipophilic, and therefore probably biliary cirrhosis would affect the amount that would be absorbed in the intestinal tract. And then the last one is lifeguards. So what you look at here is normal volunteers. And normal volunteers in this case were people, they weren't overtly ill. So they could have been office workers. They could never, office workers, people who don't go in the sun. And they measured their 25-hydroxy vitamin D levels, and you can see they came out to be about 27 nanograms per ml. Biliary cirrhosis or lipid malabsorptions are much lower because they malabsorb fat. And then the final one were lifeguards, which were all greater than 2 times what the quote normal volunteers. The lifeguards had extended exposure to sunlight. So they were what we would call vitamin D replete. So had this data been interpreted properly back then, that lifeguards would have been referred to as normal. Okay, that would have been the level of vitamin D, 25D, that you would have strived for in any given patient. The problem is, to get to that level, you would have to supplement. Average supplementation in any adult would need to be 5,000 to 6,000 international units a day to get to that level. And back then, or even today, people look at that amount of supplementation as dangerous and toxic, when in fact it's what's needed to maintain normal circulating levels of vitamin D in the absence of significant sunlight. Next slide, please. And again, we come back to how toxic is vitamin D, because that's always what everybody comes back to. And most of it is ignorance. This was perpetrated in the United States starting in 1997, when the national guidelines in the US were stated that intake of greater than 2,000 international units of vitamin D per day could be harmful to the health. Well, that made that statement is grossly in error and is an impediment to human health. Recently, 10 years ago, they redid that and arbitrarily set the upper safe limit of 4,000 units a day, which is better than 2,000, but it's still, in many cases, not enough. And the truth is, intakes of up to 10,000 units a day or more are totally safe. Now, to put this in perspective, 2,000 units or 4,000, if a human spends time in the sun, say 20 minutes in noon sun, when the sun is at its peak, a human being will make and release 10 to 20,000 units of vitamin D into their circulation within 24 hours. So it's hard to imagine that these artificial upper intake levels, which are based on no science whatsoever, they were intuitive, that they would be harmful, and they're not. Next slide, please. So in 2010, our Institute of Medicine that set these said that the optimum circulating level of vitamin D would be 20 nanograms per ml, 50 nanomoles. They also stated that levels of greater than 50 nanograms per ml are potentially harmful. Now that makes no sense whatsoever, because human beings living in nature generate levels exceeding that easily. So there's absolutely no evidence to suggest that having levels of 50 nanograms are harmful. In fact, the levels that we recommend in pregnancy, as you'll see, are 60 nanograms. 60 to 80 nanograms is what we strive for. So we're totally at odds with what they're saying here. And that is odd in the humans evolving for millennia had 25D levels far exceeding 50 nanograms. We see normal people with extended sunlight exposure that would exceed 100 nanograms per ml naturally for normal human physiology. Next slide, please. So public health issues of vitamin D deficiency during pregnancy. It's evident that vitamin D deficiency during pregnancy is a serious public health issue that affects both mother and fetus. We have a need to establish the vitamin D requirements of pregnant women seen as a vital in preventing vitamin D deficiency. And yet the recent Institute of Medicine made only a slight increase. This was, again, 10 years ago now, slight increase for the intake during pregnancy from 400 to 600 units a day. Now, a 400 to 600 unit intake of vitamin D a day will essentially do almost nothing to raise your circulating vitamin D level. In fact, it's off by a magnitude. It should be 4,000 to 6,000 units a day, as you'll see from some of our studies. Next slide, please. So back in, it's 20 years ago almost now, we decided to look at this during pregnancy. We designed a study submitted it for funding. We were granted the funding. It was several $1 million to conduct this randomized controlled trial. It was published in 2011, I think, in Journal of Bone and Mineral Research, the findings. They were quite remarkable, and I'll talk about some of those. But anyway, the study went on. It was a randomized controlled trial where we gave women 402,000 or 4,000 international units a day. Each class is stratified by race. These women were incredibly monitored for safety. In fact, you could call this study largely a safety study to make sure that the levels we are giving here didn't harm anybody. And of course, not one single patient was harmed, and we didn't see one adverse event due to our vitamin D supplementation. We had data and safety monitoring boards watching this. And in fact, we had to get from our Food and Drug Administration an approval to run this study. And that took several months and a lot of work. It's what drug companies have to do. It's called the investigational drug application to conduct this study. In the IND, you'll see in the bottom there, the FDA was obtained in May of 2002. It was the first ever awarded to an investigator to look at the action of a vitamin. Next slide. So you can go read the whole study. It's very lengthy. There's a lot of data in there. And again, a lot of it was safety. Now, this particular part of it, broken down across supplementation lines, was extraordinarily interesting. Now, keep in mind that when we started this study, we had no idea that vitamin D would be involved in any way possible of impacting birth outcomes. We're not talking about skeleton here. We're talking about, as you'll see on here, diabetes, complications of pregnancy, and things like that have nothing to do with skeleton. And they have, as you'll recall back from that slide, that first slide of all the functions of vitamin D, and these will be autocrine functions. And so it's secondary analysis again, because we didn't even know to ask these questions when we designed the study, but we had the data. And if you look all the way to the right, you'll see blue numbers, 0.046, 0.05, 0.06. And those represent significant differences in cesarean section incidence, preeclampsia, eclampsia, and gestational diabetes, general complications, and comorbidities. So what this told us was in our study is the higher levels of vitamin D we gave to these groups, the better the birth outcomes, the less of these complications that we're seeing. Now, you go back to 2009, and I presented this data at a vitamin D conference, and it caused an enormous amount of fighting because people simply didn't believe it. They said, how could vitamin D have anything to do with something other than skeleton? And I basically said, well, this is the data. This is the analyzed data. So we didn't make it up. This is what we saw. And so it opened the door, so more than 10 years ago, on the field of looking at vitamin D and how it can improve birth outcomes. Next slide, please. Now, there are a lot of naysayers about the data, okay? So people, in the last 10 years have designed studies and try to prove that vitamin D doesn't have any effect on birth outcomes. And this is one of those studies. And it's unfortunate that mainstream medicine doesn't like it, that vitamin D has these positive functions on health outcomes. They would rather develop drugs to do this instead of having simple vitamin D, which is essentially free to solve the same problems. Anyway, we look at this study done by Dan Roth in Toronto. And what they did here was that they supplemented vitamin D during pregnancy at a much lower level than we did. And where we started our supplementation in our pregnancy study at give or take 12 weeks of pregnancy into the end of the first trimester, these people started supplementing well into after the second trimester. So they're missing these women are going through vitamin D deficiency in these different studies at different times and different levels. So these studies aren't comparable. And of course, next slide, please. The article that the New England Journal had all negative findings. They supplemented an inadequate amount of vitamin D to the mother, and they waited too long in pregnancy to begin the supplementation. So they published this and said, see, the data that Hollis and his group published can't be validated, and they weren't the same studies. We wrote letters to the editor of New England Journal in that time frame, and the answers that were given back, they published the letters, and the answers that were given back by the author of the New England Journal basically never addressed the questions that we asked. So as far as I'm concerned, this article was nothing more than a poorly designed study published in what you would call a major medical journal, because they liked it that vitamin D in this study showed no positive effects on pregnancy outcomes. And that's unfortunate. Next slide, please. This slide was published, well, you go back here in 2015. This study was actually done in India. And it was a vitamin D supplementation. They started at 20 weeks. It was published in Clinical Endocrinology. You can look at the bottom reference and go find the paper. I actually reviewed this paper when it came out for Clinical Endocrinology, and I found it quite interesting. And what they found here was what we found in our initial studies. Gestational diabetes, preterm labor, complications of pregnancy. If you look on the left, placebo, these were women that were not supplemented, and then women who were supplemented. This was a randomized trial, I believe. And you can see the dramatic decrease that vitamin D caused in these different outcomes in pregnancy. Clearly, vitamin D had an effect. And this population were quite vitamin D deficient. The placebo group were quite vitamin D deficient. So the results here were quite clear to us. Next slide. So this study was a much more involved study. It was done in Iran, and I was fortunate enough to be part of this. And it was a very complicated study, very detailed. It was a randomized trial looking at the effectiveness of prenatal vitamin D deficiency screening and treatment on birth outcomes. Okay. And it was submitted to New England Journal, and it was submitted to Lancet, and of course they rejected it because it was positive findings for vitamin D. So I'm sorry to say this, but when you see articles published in JAMA, Lancet, New England Journal, and they're on vitamin D, they're going to be negative because they are not going to publish positive studies with vitamin D. And this study is a classic example. Next slide, please. So you can go look at this article again. It was published in Journal of Clinical Endocrinology and Metabolism. And here's this bar graph looking at there's quite a lot of data on here. And if you go get the article, it'll be much clearer about what you're looking at here. But you have the line. If you go to the left or the right of this graph, you'll see a line and a bunch of arrows going down, and you'll see outcomes. You'll have complications of pregnancy, preeclampsia, gestational diabetes, preterm delivery, and composite adverse outcomes during pregnancy. So if you look at that line, you'll see one, and then you'll see on the right side, which would, if arrows extend onto the right side of that line, that means there's either no effectiveness or harm. If a point falls on that line, that means that vitamin D did essentially nothing, no harm, no positive effects. But if you see dots or lines to the left, that means vitamin D had a positive outcome on those particular maladies of pregnancy, meaning vitamin D in this study decreased preeclampsia, decreased complications of pregnancy, decreased preterm delivery clearly. And it was a dramatic decrease, basically validating what we had seen 10 years earlier, and what the study in India a few years before this one actually showed. So it's clear that vitamin D in this population, again, which is a lot of vitamin D deficiency in Iran because of cultural habits, was clearly effective at preventing birth outcomes. Next slide, please. So we'll talk a little about preterm birth. Next slide. So this data was a composite of data that we had along with grassroots health. And what it shows here is gestational weeks at birth versus serum levels of 25-hydroxy-D. And what you can see is the higher serum levels of vitamin D go, the longer a woman will go into her pregnancy. And again, you're clear, you can see it that that you reach a point where it looks like the best effect is seen at 40 nanograms and on. Less than 40 nanograms, you see the increase, or you see the vitamin D causes, low levels of vitamin D causes a lower gestational age. The woman doesn't take the baby to term. Next slide, please. Just depicting what we say in preterm birth, and it's marked here, Institute of Medicine. Those are the results if you went by what our government recommends, legally recommends, or generally recommends, the IOM, and the GRH is grassroots health, which we're associated with, is what we recommend. And you can see the hazards of preterm birth greatly decreases as vitamin D levels increase. And the D levels here are listed in nanomoles per ml instead of nanograms. We go back and forth about the units. I'm not sure in India how you report it, if it's in nanomoles or nanograms. Anyway, 100 nanomoles is 40 nanograms. So again, it's clearly showing here the hazards of preterm birth with lower levels of vitamin D. Next slide. Another study I was involved with was looking at the effects of vitamin D on the outcome of asthma and wheeze, because vitamin D is known to have really profound effects on lung development. So this study was run out of Harvard. Again, it was a very expensive study, took years to do. And so I was involved in this. Next slide. It was called the VDAR study, Vitamin D Antenatal Asthma Reduction Trial is what it stood for. Now, vitamin D supplementation in mothers during pregnancy with a child at risk of asthma or allergies can prevent, this is a hypothesis, can prevent the development of asthma and allergies in this child. And this was a number of the clinical study. Next slide. So at 3 years, the study was designed to go 3 years, okay? And basically what the women were supplemented with, there were two groups. One group got 4,400 units of vitamin D per day, and the control group got 400 IUs of vitamin D per day. Now, this was a Kaplan-Meier plot of the incidence, and you can see that by giving 4,000 units a day, there was a significant amount less of asthma than in the control group. And the way this was only vitamin D supplementation during pregnancy. Once the infant was born, all vitamin D supplementation stopped. That turned out to be a weakness in the study, but this is out these are effects 3 years out. So vitamin D given in utero, given to these pregnant women, cause these lung changes in utero to result in less asthma and wheeze in these children, even 3 years after they were born. Next slide. This was another way of looking at that data. More complicated way here. What we were looking at were effective supplementation on the wheeze and asthma child stratified by the woman's initial vitamin D level. in pregnancy. So if they were lower in the beginning, they had the woman was deficient early in her pregnancy, they had a much higher rate of asthma incidence than they would have had they had significant levels in the first trimester. Next slide. The final VDART data were published in New England Journal in 2020, and they wanted 6-year data, and so we had to give them 6-year data, even though the study wasn't designed to go 6 years, and the 6-year data were negative, okay, which it didn't show an effect. So why was that? Okay, so there are a lot of issues to deal with in this study that we didn't know about when we designed it. I mean, it's complicated studies. You don't know everything when you design it. First, the compliance was poor in the minority population, and that greatly altered the final results. And what I mean about that is we have more asthma in our African American population than we do the white population. That population, of course, is grossly vitamin D deficient from the beginning. And what happens is, if you when you assign in a randomized trial, if subjects don't take their vitamin D, you would classify them as treatment group when in fact they're not being treated at all. And so it complicates the results. And those individuals end up being analyzed as treated when in fact they didn't take their medicine, and they would fall and alter the results. If we analyze the data, including baseline circulating levels of D, then the results become significant. However, okay, that's not allowed in an intent to treat model. When you publish this data, you have to publish it with your intent to treat model. And so you can't make any adjustments for any of these confounders that you see, such as non-compliance of vitamin D. Maternal vitamin D supplementation needs to begin preconception, okay, not after the first trimester is passed. Vitamin D is critical in lung development during the first trimester. So all vitamin D studies, including our own, the way we could do it is the women come into the clinic at 12 or 14 weeks, and they determine they were pregnant, and they got on the studies. Truth of the matter is, they've missed the whole first trimester, and they're going through it in a vitamin D deficient format, and it's almost certainly affecting lung development. So you can't correct the damage that's being done by supplementation later. It seems like you can minimize it, but a lot of the damage is done before we can even enroll them in the studies. Another one, maternal vitamin D supplementation needs to increase to 6,000 units a day. And we determine this by how many of the women taking vitamin D actually got to 40 nanograms or greater. And not all of them did, even on 4,000 units a day. So if this study was ever repeated, and probably is never going to be repeated in this country because of the expense, you would need to increase the supplementation during pregnancy to 6,000 units of vitamin D to see the full benefit. And vitamin D supplementation needs to be continued beyond birth, in the infant following birth. In our studies, we didn't. We ended the vitamin D supplementation when the infant was born. And so some of the effects were probably surely washed out in the years to follow. Next slide. Secondary outcomes from the VDART study has to do with preeclampsia and preterm birth. Next slide. And here's effective 25 hydroxy on preeclampsia by treatment arm in first trimester and third trimester. And I think this is better explained in the next slide. Next slide. Risk for preeclampsia by vitamin D levels. And what we mean here, we look at low, 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 high, high, low, and high, high. Low, low means the women entered into the study with a low level of vitamin D from the way that they were, okay, and they were put on the low level of supplementation. Low high means that they came in low and we put them on the high dose. High low means they came in high and we put them on the low supplementation dose. And then high, they came in high and we put them on the high dose. So you can clearly see the protection effect that vitamin D imparts, but it's also very important to see here that if a woman comes in high, that means she was undoubtedly high from the time she conceived. This was a lifestyle issue. She spent a lot of time outside, whatever. Anyway, her vitamin D levels were quite high when she got pregnant, and that was a big advantage in preventing preeclampsia. Next slide, please. In this slide, this was published in the Journal of Clinical Endocrinology and Metabolism in 2016, I believe. And this is extremely interesting, this slide, because what it shows is risk of preeclampsia based on the x-axis and the vitamin D on the concentrations on the other axis. Vitamin D level on the x-axis, preeclampsia on the y-axis. So if you look at this close, you'll see on the bottom it says controls 745 patients, and on top cases 73 patients. The cases mean those were the cases of our women that actually developed preeclampsia. So if you look at the graph, okay, and you plot it, you can see that, again, you come back to this 40 nanogram or 100 nanomole level. In our study, and this was what they were when they came into our study. So this is probably what they were when they conceived pregnancy. If they conceived pregnancy and they were greater than 40 nanograms per ml, we saw 0 events of preeclampsia in those women. So early on, vitamin D supplementation is very important. And if you understand some of the things about vitamin D supplementation and placental integrity, it's involved in the normalization of angiogenesis, which is again related to preeclampsia. If the blood flow is not normal in a placenta and formed early on, it leads to problems with blood pressure and preeclampsia. And it appears that largely if this happens in the first trimester in vitamin D deficiency, later on you really can't correct it. So it's very important to have vitamin D levels at 40 nanograms or higher when a woman becomes pregnant. Next slide, please. And here was some data that just came out. This is really interesting. It was showing vitamin D deficiency has been related to different issues of pain management. And this was a recent study that's come out with the last few months. And what these found was on the y-axis, you have labor pain scores, how much pain these women were in when they were going through labor, and then the level of vitamin D, and meaning during 2 to 3 centimeters dilation, 4 to 7 centimeters dilation. And you can clearly see here that the higher vitamin D levels resulted in far less labor pain than lower vitamin D levels, and it was quite significant. So this appears to be another benefit of high vitamin D levels during pregnancy, is your labor will go better and your labor pain will be a lot better. So next slide, please. This slide simply shows when we did these studies, you plot these interaction graphs, and it shows what vitamin D is associated with in the control of gene function. And if you look at these vitamin D effects, lupus, connective tissue disease, immune functions disease, all these things that I explained were paracrine and endocrine function and have a positive effect on pregnancy outcomes that have nothing to do with calcium homeostasis. These things have to do with inflammation, autoimmune disease, infection. And so, again, vitamin D imparts positive effects on all of these different metabolic functions by control of gene function. Next slide. There was another study that was run when we ran the VDAR. It was called the COPSAC study. It was similar than what we did, but they used different amounts and started at different times during pregnancy. The study was largely negative with preventing childhood asthma, but again, it was a different study than we ran. We gave more vitamin D and started earlier. But what this study did show was demonstrated that vitamin D provided increased skeletal mineralization at children at 6 years of age. We didn't look for that, but this study did. So again, if you go back to one of the earlier slides where I showed the baby with the craniatates with the abnormal skull, vitamin D has an effect in utero that will increase mineralization of the child's skeleton even 6 years following birth, simply by what's occurring in utero. So this is a classic endocrine function of vitamin D controlling calcium homeostasis and skeletal metabolism and mineralization. Next slide. Vitamin D has probably effects on both female and male fertility. In the female, it regulates sex hormone steroidogenesis, has effect on polycystic ovary syndrome, ovulation dysfunction, and pathogenesis of endometriosis. All of these things contributing to infertility. Vitamin D in the United States is pretty much used in all fertility clinics when women are having trouble conceiving. Next slide. And from a male standpoint, there's modulation of testes function due to spermatogenesis and vitamin D. In fact, there's more. It's interesting is that in the human body, there's more vitamin D activating enzyme in the liver to make 25D. The second tissue that has the most 25-hydroxy activity activation is actually the testes. So it seems to be quite important in the function of spermatogenesis in the male. Next slide. So as we conclude the lecture, vitamin D intakes up to 10,000 IUs a day and circulating levels of vitamin D levels up to 100 nanograms or 250 nanomoles are normal in human physiology. It occurs naturally. Do not treat vitamin D at these levels as a poison or harmful. Vitamin D supplement at the levels that we tested have never resulted in a single adverse event in pregnant women or any other study that we've looked at, meaning we've had to follow all these subjects looking for adverse events, meaning hypercalcemia, hypercalciuria, the classic things, and we have never seen a single adverse event, not one, in all of the thousands of patients I've been involved with when we looked at these things. Vitamin D supplementation during pregnancy is vital in the protection of enhancement of neonatal skeletal development, as I showed in the COPSAC study, as well as in a prevention of birth complications, including preterm birth, preeclampsia, and gestational diabetes. Prenatal vitamin also appears effective in enhancing neonatal lung development and preventing the development of childhood asthma and wheeze. Next slide. Now, this happened only a couple of years ago. And in the United States, you have to be careful about what label claims you make. So if a company makes a vitamin D supplement and sells it to the public, you can't put on the label that vitamin D reduces the incidence of cancer. The FDA won't allow it. What the FDA has allowed for a long time is that vitamin D enhances the calcium homeostasis and skeletal outcomes and mineral. That's been allowed. Okay, nothing else has ever been allowed to be put on vitamin D supplementations until about a year ago. And based on the data that I've shown you, our FDA now allows the label claim on vitamin D supplements that basically states vitamin D may aid in the prevention of birth complications during pregnancy. And that's major progress, okay, in this country that vitamin manufacturers can now state this as a label claim on their product. Now, what the FDA didn't say is how much vitamin D you should take. What they basically said is the vitamin D intake should be up to between the physician and the woman and should be monitored to achieve the appropriate level desired, which in our estimation is a minimum of 40 nanograms or 100 nanomolars up to 80 nanograms per ml, which we think is pretty much the ideal levels that you want to take. Next slide. I'd like to thank you for listening to the lecture, and I hope to be taking questions later for this lecture. Thank you.
A masterly lecture on vitamin D, particularly summarizing the last couple of decades old data and all the data with its pros and cons. But what comes out, there's a huge clarity on the maternal outcomes. In maternal outcomes, what came clear was that pregnancy-related outcomes, birth-related outcomes, facilitating the delivery, lesser number of cesareans, huge amount of data already available. If you have vitamin D deficiency, higher prevalence of pregnancy-related hypertension, higher prevalence of hypertension in women who have pre-gestational diabetes, worsening of that diabetes, higher prevalence of gestational diabetes. So long as fetal outcomes are concerned, skeletal growth and skeletal fragility and its association with vitamin D seems to be now very well correlated. Like, as Professor Hollis very aptly talked about that Danish study at the fag end, that at 6 years, the bone mineral density was much better. So, if you look back, what I gather from this talk, we seem to be doing too little and too late, and then looking for better outcomes. So in endocrinology, like, Rishi, we every time talk about, if a girl has type 1 diabetes and she wants to get pregnant, she should walk into pregnancy when blood sugar is ideally controlled, not that we control it during pregnancy. In a similar fashion, if somebody is hypothyroid or thyrotoxic, walk into pregnancy when you are strictly euthyroid as per the pregnancy parameters. So I would say that, in a similar fashion, when a pregnancy is planned, pre-pregnancy vitamin D should be optimal. One. Number two, supplementation with a sufficient amount of vitamin D is safe. I still remember in my younger days, we used to feel very nervy if cholecalciferol level would be more than 20 nanograms, thinking of getting a hypercalcemia or renal calculi. But then it became quite clear that at least we may not be chivalrous enough to go up to 100, but up to 50, it seems to be reasonably safe. I loved one comment that Professor Bruce Hollis made, people who live in nature, outside, their vitamin D level is being very high. I'm reminded of a study, at some stage we were trying to see that if government could be motivated to do some vitamin D supplementation with some, food stuff. And there was a lovely paper published by Ravindra Goswami. And he did this study on those, workers in the people who make those multi-story buildings and all that. Those skeleton-like laborers. He found their vitamin D levels were sky high. So they were again saying that much higher levels seem to be available for our day-to-day metabolism in the body, in the nature. And now one thing became very clear from this talk today. Vitamin D being fundamentally a hormone, a steroid-like hormone, there is more to it than bone health alone. And we invariably have associated it with bone health for decades. I think from that paradigm, we need to move a bit so that we understand and reanalyze the data that is available with us today. Dr. Rishi.
Thank you, Professor Bruce Salis, for a wonderful and insight talk. And what I could understand, a beautiful thing that I understood out of it is the V's in up to 3 years of age. And if you supplement the vitamin D in a critical period of gestation before 3 months, if you supplemented later, the V's part would possibly would not be taken care of. So this was a wonderful thing that I've learned. And the rest thing, is there any questions, Dr. A.K. Singh, in this, or we'll discuss it later?
Sir, you can carry forward if any question comes.
I think one small question is coming in my mind. I need to ask, is there any role of vitamin D in adult asthma? Professor Bruce, are you hearing me?
In relation to what?
Role of vitamin D in adult asthma, V's, adult V's.
Oh, adult asthma?
Yeah.
There may well be a role of vitamin D in adult asthma, but vitamin D in the ethology of asthma probably has more to do with the lung development, and that, of course, occurs through birth. And that's one of the things in our study is that we learned in the VDART study was that to do the study in an optimal fashion, you really need to start the supplementation, like you said, or was mentioned, prior to getting pregnant. Because if you start the supplementation like we did towards the end of the first trimester, you've missed a lot of the lung development time that is the lung development that's already taken place. And if it's taken place in a vitamin D deficient environment, I don't think that those insults can be corrected. You might be able to make them a little better, but to be vitamin D replete during the whole first trimester of pregnancy is very important. Therefore, you need to really be vitamin D replete when a woman conceives.
Thank you so much. I think with this,
you know what it effectively means today, understanding. In our younger days, we always used to believe that kidney is the only source of 1-alpha hydroxylase, and that makes 1,25 dihydroxylase, the product available, dihydroxycholecalciferol available for metabolism. Now, many tissues have been known to contain this 1-alpha hydroxylase activity, but albeit in a relatively smallish quantity. You see, Dr. Bruce Hollis talked about the testes. And there it works as a paracrine hormone. Once, it converts this 25 hydroxycholecalciferol to 125. It's a very minuscule, which has a local paracrine activity. In a similar fashion, we have this 1-alpha hydroxylase in the lungs. And there are certain things that are relevant at the stage of development. And in the lungs, this is relevant when the lung is getting developed, in that process, fetal to juvenile life. It is something like, somebody developing the mental deficiency because of iodine deficiency. Now, replacing iodine deficiency will not retrieve that mental deficiency. But if it was given in time. So I think that's what Bruce Hollis is trying to tell us, that if we had made use of it at the right time, but we have lost that time. Rishi.
Yes, and the same thing happens. The same thing happens in the placenta, in angiogenesis early in development of the placenta, and that's why vitamin D looks to be, again, very important in preventing preeclampsia in the first trimester, because if that placenta develops in an environment of vitamin D deficiency, the angiogenesis that takes place is probably not normal. And once that occurs, you can't fix it. Meaning that supplementation later cannot fix those initial insults that were made by the initial deficiency.
Yeah, thank you so much. I think we have another panel discussion. So with this, over to, should we conclude, Dr. Jargar? This part. So the conclusion to this part. Thank you very much, Mr. Ashok Singh, Cadila Pharmaceutical, and everyone. And it was really a wonderful talk. You want to say something, Professor Alice? You wanted to say something? Yeah.
Yeah, thanks for letting me do it. And it's very early in the morning here. It's
Yes, yes,
3:30
yeah,
a.m. in
yeah.
the morning. So it's I had to wake up and clear my mind to actually to speak. But
Truly appreciable. Truly appreciable when you are able to answer all this. I mean, that's again
yeah,
a wonderful thing. Thank you so
Thank
much,
you.
and thank you for your pains. And
Okay.
over to
Thank you very much.
with one concluding remark that vitamin D is essential. We get patients of pre-counseling those who are going to conceive diabetes. So one request to everyone whosoever is listening, please look at vitamin D. Either get vitamin D tested, if not, at least give a supplementation of vitamin D. So with this, thank you so much, Ashok Singh, Cadera Pharmaceutical, Professor Jargar, and entire faculty who is with us, and over to Mr. A.K. Singh. Mr. Ashok
Thank
Singh.
you. Thanks.
Thank you. Thank you, Professor Wallace, for waking up in the morning and taking out time. And really, it's amazing. And you are in
Thank you.
70s. You are young.
Yeah. All right. Thanks.
Okay. Bye-bye.
So thanks, Dr. Holish, and thank you, Dr. Rishi Shukla and Dr. Jargar for a wonderful deliberations. And we would like to facilitate the faculty. So can we have the memento, please? With this, we have come to the second session of our program, and this is on vitamin D, New Era Brahmastra. To carry forward these programs, we have got galaxy of leaders, thought leaders, eminent speakers of national and international repute. Intro, Abhi, please.
Dr. Arpan Dev Bhattacharya. He is a consultant endocrinologist at Manipal Hospital, Bangalore. He is also a professor of endocrinology at JJM Medical College. He is co-chair of Shivajyoti Hospital, Bangalore. Dr. Arpan has pioneered the fellowship program in diabetes and endocrinology with Manipal Academy of Higher Education to train post-MD physicians. He has more than 120 publications in various national and international journals. Dr. Ramesh Goyal. He is Senior Consultant and HOD, Department of Endocrinology and Diabetes at Apollo Hospitals, Ahmedabad. He is also Consultant Endocrinologist and Diabetologist, Endocrine Solutions at Vijay Crossroads, Ahmedabad. He is faculty for certificate course in evidence-based diabetes management and certificate course in management of thyroid disorders awarded by Public Health Foundation of India. He was a faculty for fellowship in diabetes awarded by Medversity and the Royal Liverpool Academy, UK, conducted at Apollo Hospital, Ahmedabad. He was a former member of National Advisory Board of Indian Journal of Endocrinology and Metabolism. He was awarded as Best Diabetologist in 2018 and Best Endocrinologist in 2018 and 19 in Ahmedabad by the Times of India. Dr. Subodh Bansal. He is Consultant Endocrinologist and Professor of Medicine and Endocrinology at SAIMS Medical College and PG Institute, Indore. He is the President of AP Indore and Diabetes Association, Indore. He is an active member of many medical associations. He has a remarkable contribution in many publications and has attended many national and international conferences. Dr. Saket Kant. He is a consultant endocrinologist, adult and pediatric at Max Super Speciality Hospitals, Balaji Action Medical and Cancer Institute, Delhi. He has authored over 30 national and international publications. He received the Best Paper Published Award at the 14th ESI A.V. Gandhi Awards in 2016. He is the reviewer of following publications: Endocrinology, Diabetes and Metabolism Case Reports, Bioscientific Publishing, Bristol, UK, Journal of Medical Case Reports, Biomed Central, Springer Nature. International Journal of Diabetes in Developing Countries, Springer Nature. Indian Journal of Endocrinology and Metabolism, Walters Kluwer. Clinical Epidemiology and Global Health, Elsevier. He is the editor of the International Journal of Diabetic Dyslipidemia, Salubris. He has attended many national and regional conferences as speaker, panelist, moderator, and as chairperson. He is the member of Endocrine Society, USA, American Association of Clinical Endocrinologists, AACE, and American Diabetes Association, ADA. Dr. Amitabh Sur. He is a senior consultant endocrinologist at Peerless Hospital, Kolkata. He is member of Endocrine Society, USA, American Association of Clinical Endocrinologists, AACE, and RSSDI. He won the first prize in scientific case presentation in annual conference of Assam Endocrinology Society in 2017. His research interests include thyroidology, pediatric endocrinology, obesity, and osteoporosis. Dr. Anand Kishore Pal. He is a professor and ex-head Department of Orthopedics and Traumatology at IPG-MER at SSKM Medical College, Kolkata. His long list of awards include A.A. Mehta Gold Medal in the year 2002, Best Scientific Presentation of a Session in IOA-CON 2003, Best Paper in Implant Section as co-author in IOA-CON 2004, Johnson & Johnson Traveling Fellowship of IOA in 2007, S.N. Bakshi Gold Medal Award for Best Publication in Indian Journal of Orthopedics in 2012, Joy Patankar Gold Medal Award for the Best Paper Presentation in IOA-CON 2019. Dr. Rajat Agrawal. He is the Additional Director and Head, Department of Critical Care Medicine at Fortis Escort Heart Institute, New Delhi. He is also the Teacher of Critical Care Medicine and Diplomate in National Board and Indian Society of Critical Care Medicine. He was the invited speaker at National Convention of GMA, Ghaziabad, on e-healthcare. He was awarded as the Best Doctor of the Year at FEHI 2011. He was given the Fortis Living of Value Award for saving a life of pregnant lady with abortion and septic shock in 2015.
Dr. Arpandev Bhattacharya. May I request Dr. Arpandev Bhattacharya to take forward this program, please? Over to Arpan.
Thank you very much. Thanks very much. Even if it is a ninth edition, I think mine is second edition of doing and moderating this session. As all of you who are listening to us, you will feel very privileged that in the rare situation you will be see so many people and starting at the beginning a wonderful talk about the role of vitamin D and in pregnancy and its well-being with the neonates. Days have come, actually, it is very difficult for our people that we get a prescription, we should be leaving anybody to leave our room without a prescription, without a vitamin D. So all the delegates who are listening to us, a sincere request, put your questions. We have got some questions. Before you ask, I would like to clarify some of my doubts from all our panelists. So can I request all the panelists, please unmute yourself, Dr. Paul, Dr. Rajat, Dr. Ramesh. So can we start with Dr. Ramesh? Now, in your clinical practice, do you check routinely vitamin D? And in that case, what is your prevalence of vitamin D deficiency?
Dr. Arpan, I don't routinely check in all patients visiting to my OPD, but since I am associated with Apollo Hospital also, I get from the health checkup, and in our package, vitamin D is included in the health checkup program. So indirectly, most of the patients I see end up coming with a vitamin D report. And my observation is that the vitamin D deficiency is very common in elderly, particularly if I put a arbitrary cutoff in patients, diabetic patients more than 60 years of age. I see vitamin deficiency in more than 95% of people, unless they are taking some form of vitamin D supplement. And even in younger age group, because we do see diabetics in their 30s and 40s very commonly now, the prevalence is somewhere around 80%. Again, with the remark that the people who are not taking vitamin D supplement. Why I'm stressing this point repeatedly? Because people are becoming more and more aware about the role of vitamin D supplement, and particularly after this COVID-19 or during this COVID-19 pandemic, thanks to media, the people have become more aware that certain vitamins like vitamin D or vitamin C supplementation might help in preventing or reducing the severity of COVID-19. So, in city like Ahmedabad, I see lot of people they take vitamin D supplementation either prescribed by their family doctors, or some of them they take it by themselves also. I think which is slightly a disturbing trend also, that yeah, many people they are overexposed to vitamin D, and I have seen vitamin D levels of more than 100 in many of my patients in Apollo.
Thank you very much. I think it is very clear. Something prevalence is so high that basically not much point in routine checkup. We also try to nicely hear from Dr. Bruce is that 100 cutoff and toxicity chance is very less. We also try to believe that the best level probably between 40 and 80. And Dr. Jalgar was mentioning around 50 should be very comfortable. And can you move to Dr. Shubodh to ask this now? Once we know this, now what is the cutoff that you follow in our clinical practice?
Cutoff, as rightly said by Dr. Goyal, that we don't really routinely doing the vitamin D levels. But if you ask me, 20 is not the level. It is 30 nanogram per ml, or you can just say it, 75 nanomole per liter is the cutoff where we really see them. They have bone as well as muscular and other problems are there. So bone health is affected if the vitamin D levels are less than 30 nanogram per ml, and that's the time we should really supplement the proper dosage of vitamin D, and this is what we have been doing. So if you ask me, I take the cutoff of 30, and if rightly said by Dr. Ramesh that we see these, Ranbaxy, Lal, other pathologists, people are coming, but the bundles of the report, we don't advise them, but they bring, and you see there's a 5, 7, 10, even less than 4, I have seen the vitamin D levels. So that's the, and if you ask them, they may not have many symptoms. But if you correct that vitamin D after 8 weeks or after 3 months, they come back and they feel much better. So that is there. So if you ask me the single level of cutoff, that is 30 nanomole per ml I'm taking. That's the answer to your question.
30 nanogram.
Nanogram,
Yeah.
nanogram per ml or 75 nanomole per liter. So either you can convert it. Yes.
That's very clear. Thanks very much. Can I just, Dr. Shakat, can I ask you a bit of, so we have D2 and we have D3, argocalciferol and cholecalciferol. So vitamin D is D2 or D3 or D2 and D3. Now, Dr. Shakat, do you find any difference in looking into D2 and D3 for supplementation, or we just do a standard of cholecalciferol or D3 supplementation?
Yes, a lot of labs would not be doing a differential D2, D3. They would be giving a D3 value. Would not make much sense because the bioavailability of D3 may be somewhat higher than D2, but we will be looking at the levels. But we have to be very careful because while supplementing without a vitamin D level, we always have to look at how many consultants or orthopedician the patient has seen. Because I have seen a lot of toxicity coming in Delhi, patients seeing a lot of doctors before coming to me and taking vitamin D supplementation from a lot of doctors, and they have vitamin D toxicity. The second thing I would like to emphasize, please get a calcium level before you start vitamin D supplementation for your patients. I have burned my fingers once or twice. A young female, 25-year-old female came to me with classical symptoms, vasomalacia, pains all over. She had rib tenderness also, was given vitamin D. She had a vitamin D level that was pretty low, around 5 nanogram per nanogram, and the patient was given vitamin D, and 3 days later she landed into a hypercalcemic crisis because she was basically primary hyperpara. She had low vitamin D levels because there was high conversion because of PTH. And 3 days later, I saw her in hypercalcemia admitted in the ward. So we have to be very careful before going on for vitamin D supplementation, either blindly or looking at the levels to get a calcium level also done.
This is actually fantastic. I can't agree with many more, but the only problem for the clinician or periphery to check a calcium level, but the justification is absolutely perfect. If you are a vitamin D deficient for a long time, your P parathyroid gland becoming autonomous, you give vitamin D, this adding is a fuel to the fire situation, you will develop hypercalcemia. Absolutely right. But we need to make our physicians aware of this. Is very good. Okay, I'm just going quickly a bit of so that we can cover all the panelists here. Now, Dr. Amitabh Shur, I know it is very, very difficult question. So we have heard Professor Bruce is telling, we have heard our 3 endocrinologists talking. So according to you, Amitabh, what are the unmet needs for us about the vitamin D supplementation?
Sir, we do see various formulations already available in the form of gels, sachets, soft gel, etc. So I don't consider there is a lot of problem in supplementing patients after testing for vitamin D deficiency, because the existing formulations, if we use them judiciously, do help us in achieving the vitamin D in the target range. I don't feel any difficulty in using them at the present moment. Only thing is we have to consider using them judiciously. As Dr. Saket already said, that we must test the vitamin D level before starting the supplementation. And we should be using supplementation as closer to the physiological as closer to the physiological replacement as possible. Like, for example, I still see patients who have been given that injectable vitamin D 6 lakhs unit stat and then weekly or monthly. This is something which is most unphysiological. So should be avoided unless there is serious issues with the compliance of the patient. 60,000 weekly replacement for 8 to 12 weeks is something which is acceptable because of the larger therapeutic window of vitamin D. But then if compliance is not an issue, patient is very compliant, then probably the daily supplementation of 1,000 or 2,000 units, depending on the age and requirement of the patient, probably is the most physiological way of replenishing. So if you replenish it in physiological way, then I think it is okay.
There was a question from the audience, Amitabh, while you were on the mic, that what are the indications of giving injectable vitamin D? I think I'm going to ask the similar question to Dr. Rajat later, but in your clinical practice, what are the indications of giving an injectable vitamin D?
Okay, sir, I got it. Sir, in my opinion, the only point where you should consider giving an injectable vitamin D 6 lakh unit, where in documented case of ricket due to vitamin D deficiency, where you have serious doubt that a patient even may not return. Like in that situation where compliance is a big issue, only then the injectable form of vitamin D, that 6 lakh unit, has to be given. Otherwise, it's something which is outdated. We don't follow it in our practice. We tend to replace it daily. That's the best way. If that is not possible, many times that is difficult, then the weekly supplementation is something which is good, which is good enough.
Right.
Yes. In our younger days, we used to readily give those injections because that was a time when, vitamin D deficiency was not characterized the way characterized it today, looking at vitamin D level. We'll be looking at that gross rickets. We'll look at the huge osteomalacia rickets. But it was relevant at that time because otherwise nutrition stats also was not all that good. In the last 2 decades or more, there is no justification because, if you use sachet, that sort of a toxicity that Saket was talking about would be relatively very uncommon, unless you have, as you were very aptly saying, tertiary hyperparathyroidism. Because those 60 units can do damn little damage if you take the fact into consideration, and even up to 100 nanograms per mil is going to be okay. So preferably avoid the injectables at all. If you have to give it, and there are no weekly courses of vitamin D, that needs to be understood. I've seen many of my colleagues writing weekly courses for 6 weeks, one injection, to be repeated later on. And those are the recipes for damage rather than what Saket was about. Secondary or tertiary hyperparathyroidism would be an anecdotal case, but this will be a societal problem.
Right. Okay. Yeah, thank you. Yes.
Okay. See, this is a oily preparation. Absorption is a problem. Pain is a problem. You don't know how much the bioavailability is there. I had an anecdotal case, 10 years ago. The lady was given injectable vitamin D 6 lakhs, and she continued for 6 months every week. And she came with 14 milligram per deciliter of calcium. Creatinine was 3.5. At the age of 65, we had to admit, did it. It was sky high vitamin D. And we just waited. Some, steroids were given. With time, things settled. So this is the problem. They feel better. Injection is always better. So that is the big problem. So bioavailability, the pain, and you are not sure how many, injections patient is going to take. So those problems are there with injectable. That's what I feel.
Thank you. Can you move to Dr. Paul?
हॉटस्पॉट আছে देखिए
Can you move to Dr. Paul now?
Hey sister.
Sir, can I?
Sister.
Sir, can I?
Yes, Amita, please.
Sir, 9 out of 10 patients whom we see for toxicity part of vitamin D, that is hypercalcemia or intracranial hypertension, they have taken injectable vitamin D. It is very, very rare with the soft gel preparation and other sachet and all.
Right. Dr. Paul?
Mobile.
Dr. Paul, can you hear us? Is it Dr. Paul is in mute or I'm not very sure. Dr. Paul, can you hear us? Can you hear us, Dr. Paul? No?
Hotspot.
Arpandev, you can move on.
I think we'll go to Dr. Rajat Agarwal. Now, obviously, we have so many questions to ask you. Dr. Rajat?
Hello, sir.
You're using in your ICU setup. What is your practice?
Just a minute.
You are picking somebody who is the vitamin D deficient in your patient, in your setup, and COVID days, and its immunomodulatory action. So I know there are a lot of things I'm asking, but these are the things I would like to get clarified from you.
So, sir, you are rightly said that, and many other panelists have said that the role of vitamin D and the interest in vitamin D developed significantly during the COVID era. Before that, yes, it was linked only to bone and tissue metabolism, and my esteemed panelists are more accustomed to treating those disorders rather than me. But during the COVID era, when we realized that in COVID-19, basically, it is the viral replication and the immunological response, immunomodulation, which causes the damage. So many studies have come up subsequently about the immunomodulation, and vitamin D is one of those agents. One of the articles published, interestingly, recently in Nature in May 2021 have used 60,000 units per day as a pulse therapy of oral vitamin D for 10 days, and they compared with a placebo. And though they did not find any differences in the outcome in the patients in the end hospital rates, but in terms of markers of inflammation like CRP, etc., there was reduction. Plus, there was improvement in overall general well-being rates. So still, I would say, to be honest, the immunomodulation with high dose vitamin D is still a matter of study. It's still under a lot of studies are going on. It has not been validated in very large, robust trials, which we need a randomized trial on a large scale to know the validity of this molecule. Having said that, along with vitamin C, we have used in COVID patients in mild to moderate diseases, vitamin D supplementation. And interestingly, we found that patients who had deficiency, because we use in ICUs, I mean, like we used to do a battery of tests. So we started doing vitamin D levels subsequently in relatively stable patients, and those who had less vitamin D, less than 20, they responded better to supplementation of vitamin D, and not those who had higher levels. Now, it was an anecdotal, I mean, we could not do a randomized trial on that, I agree, but that was the small thing which we found when we started using vitamin D in COVID-19 patients.
Yeah, but what will be the dose in your setup? How we are using? Are you giving via Riles tube or are you giving by injection?
Sir, in a majority of patients in mild to moderate disease are usually able to take orally. So we give 60,000 units per weekly for 4 to 6 weeks if they are isolated at home. If they are admitted in the hospitals, then we are giving 6,000 units per week for 4 to 6 weeks as per the vitamin D3 levels. If patients are on ventilator, we tried giving injectable vitamin 3, but then there was an issue of coagulopathy and we are not sure about giving intramuscular developing hematomas. So we stopped that practice and we only switched to oral vitamin D supplementation in mild to moderate.
And just a bit more poking yourself that you told that immunomodulatory still it is a theory, we don't have data. But just I'm asking, so what, do you think that level for the immunomodulatory benefit should be blood level should be higher than our normal practice of 40-50 nanogram?
I believe so, sir. And I believe that in sepsis now, there's a lot of concepts coming up for immunomodulation, because now also we say that sepsis is more of a dysregulated immune response rather than only the bacterial infection. So levels 50 to 100, as our speakers have said, that are quite safe. And diseases like, it should be explored in diseases like rheumatoid arthritis, celiac disease, where immunomodulation may play a very important role. So vitamin D has a potential role in those studies as well, in those diseases as well, though we need to have robust data before we can make it as on a larger practice.
Thank you. Dr. Paul, you are with us? Dr. Paul?
Dr. Arpan, a comment on this.
Dr. Paul was very much here, sir.
Yeah, but he was not able to hear, I think. Can you hear me?
Dr. Paul, can you unmute? Dr. Paul, can you unmute, please?
Let me ask one question to him and then you'll go to Dr. Jargar. Dr. Paul?
Ashokji, can you phone him?
Okay. Dr. Jargar, please. You wanted to make it.
Hello? Yes. Hello?
You can hear me, sir?
Yes, yes.
Sir, he can hear
You can hear me, sir?
Yes.
We
Sir, he can hear now.
not able to hear you.
You can hear me, Dr. Paul?
Hear.
No, I don't think he can hear. Dr. Jargar, you had a point to make.
You know, Arpan, we had a global meeting of researchers in Hyderabad on vitamin D about a decade and a half back in Hyderabad, Coromandel, Hyderabad. And there was an associate professor from Harvard Medical School who has been exclusively working on this autoimmunity and vitamin D.
Yes.
And people do believe, you know, as Professor Hollis was saying, that people probably who have been exposed to a significant vitamin D deficiency for a prolonged period have a more chance of having these autoimmune disorders. But then, you know, again, the way he was saying that correcting it prior to pregnancy, in a similar fashion, a population which moves on in life in an eucalcemic state where vitamin D is optimal, then you can associate them with a lesser degree of these autoimmune diseases. In fact, the correlation they had found so strong, Harvard has created a separate chair for understanding the vitamin D for autoimmune disorders. And she was occupying a chair of the associate professor there. So means there is something, but might take a while.
Yeah, correct. There is an audience question. I think we should encourage, I am asking my question, audience question. Can I ask this to Dr. Ramesh? Now, question is on glucose homeostasis, and we have some lot of theses done by our juniors and our contemporary people have shown something. How much clinically relevant is this vitamin D deficiency and the problem in the glucose homeostasis? Or in people with the diabetes, if you replace vitamin D, how much clinically you see the benefit of glycemic control?
First of all, Dr. Arpan, there is similarity between both the type 2 diabetes and vitamin D deficiency, and it is the common occurrence of both these states in our population. So diabetes is very common in our country, and so is vitamin D deficiency. Now, if we go through the literature says that deficiency of vitamin D can lead to insulin resistance, and it can also lead to reduced insulin secretion from the beta cell. So that is the pathophysiology part. And the literature also quotes that if there is a severe vitamin D deficiency, that is vitamin D levels less than 12 nanogram per ml, then chances of this metabolic and the so-called the metabolic syndrome abnormalities are more. So in my practice, what I have observed that most of, as I said, my vitamin D type 2 diabetic patients, they are also having vitamin D deficiency. And how much it impacts the control of the blood glucose, that I am not very sure, because we routinely supplement vitamin D in all vitamin D deficient individuals. So what is the contribution of OADs, insulin, and vitamin D in management of type 2 diabetes? That I'm not very sure. But
Very
there is
true.
a
Very true.
there is a definite epidemiological association between high prevalence of diabetes and vitamin D deficiency.
I think Dr. Paul is here. Dr. Paul, you have decades of experience in clinical practice and in the teaching. Now, what is your opinion, experience on the vitamin D replacement and the fracture union, and also in people with osteoporosis? Are you routinely using them, and what sort of protocol you are following?
Yes. So it is a very important question. Thank you for the compliment. Just I want to share my experience. That is the osteoporosis, and just I'm going rightly to your answer. I'm just going to little bit back, because osteoporosis and the osteoarthrosis both are related with the hereditary problems. And there is a during pregnancy, the vitamin D level, as we have already discussed in the morning, it is extremely important. So for determining the development of the osteoporosis and osteoarthrosis in the later part of the life. So there are some environmental factors and also the vitamin D level during the pregnancy, which some modulate some gene expression, which will lead to some the development of osteoporosis and osteoarthrosis in the later part of the life. Now the fracture healing, yes. There are two types of fracture healing. One is the primary healing, where there is no gap between the fracture, almost it is undisplaced fracture, or where the fracture is anatomically reduced with the help of the plate and screws. And then the fracture healing is occurred during the remodeling of the bone process, remodeling process. And another is the secondary fracture healing, where there is some little bit gap persists between the fracture line, that may be due to the inadequately treated fracture or some displaced fracture, and that fracture is well healed by the callus formation. So both in conditions where it is seen, there are several studies which showed that the calcium, the supplementation of the calcium and vitamin D, especially the 700 international unit per day vitamin D supplementation, and calcium, especially 1200 milligram calcium, especially for the adults I am talking about. So this amount of supplementation, so basically that increases the bone mineral density, and that is directly related with this callus formation. And there are two studies. Is already it is a huge. There is a meta-analysis which showed that this amount of supplementation, calcium 1200 milligram per day, and vitamin D at least 700 international unit per day supplementation is sufficient enough for fracture healing. That is most important. Now the osteoporosis, yes, osteoporosis, this is a very vast condition. There are type 1 and type 2 osteoporosis, and then both the condition, as you have already shown, vitamin D is related with the steroidogenesis, and vitamin D is directly related with this, the formation of the testosterone. I'm sharing a extremely amazing fact. That is can you say, have you seen the length of the ring finger and the index finger? So basically, this length of the index finger and the, if you see, they're in all male person, their index finger is little bit higher than the ring finger. Sorry, the ring finger length is little bit higher than the index finger. It is basically due to, is related with the testosterone level, and this testosterone level in this maternal womb is directly related with this length of the ring finger. Whereas in case of female, if you see if any lady present in our discussion, basically the length of the index and the ring finger are equal because they are lacking testosterone. So if you consider that there are much more testosterone level in a maternal womb, so there is a high ring finger length than the index finger. So if there is a high testosterone level, there's a high length of the ring finger, there are high risk of the prostate cancer, as also the osteoarthrosis and osteoporosis in the later life. This is the study proves. So on the other side, if the testosterone level is less, the length of the ring finger is less length of the index finger will be much more. If the length of the index finger is much more, they are very much related with the cardiac problem, because testosterone is they are safe for the cardiac safe cardiac they protect the cardiac homeostasis. So these are the facts. So even just after the birth, if you see the length, that may predict the development of osteoporosis and osteoarthrosis in the future.
Okay, thanks very much. And we had one of the audience question about sarcopenia in elderly people, whom I'm going to ask. Dr. Shaket, you are with us? Dr. Shaket, how much
I guess
importance is sarcopenia in elderly and with the vitamin D deficiency?
it is a very relevant question. Elderly, in fact, start having more sarcopenia because of lesser mobility that they have. And in fact, osteomalacia in the elderly, because it will lead to proximal myopathy, would increase the risk of falls and fractures also. So very important that elderly should be counseled on vitamin D deficiency, how to take some food items that can basically alleviate the vitamin D deficiency. They should have appropriate levels of vitamin D by supplementation. They should be counseled about osteoporosis also, and to decrease the falls also, because vitamin D would decrease proximal myopathy and sarcopenia also. It's very, very important. Probably the two most important phases of life that are important, as Professor Holick also already said, it is the pre-pregnancy state, the pregnant state. I guess two more states that are very important are the time that children achieve the peak bone mass. That is a very important phase for vitamin D deficiency, because that would decide how severe osteoporosis would be in our children later in life. And the second is the elderly population, the pale elderly population with sarcopenia, proximal myopathy, with increased risk of falls. That is another very important area that we should focus on: children achieving the peak bone mass and the elderly.
Thanks very much. Thanks, Dr. Shaket. I think what I understood that as it looks like that it will be very difficult to leave anybody in our prescription without vitamin D. So more or less we practice that giving a 60K twice a week. I understood from Dr. Bruce that for pregnancy people, probably 6,000 per day means 60K we are giving 3 times a month. That's probably the thing. And because of the short of time, I was actually enjoying. I think we are going to close for the last comment from Dr. Paul.
Yes, that is one important, that is sarcopenia. Just I want to share my experience, because osteoporosis, it is not the disease of the bone, it is also a disease of the muscle itself. And it is proved that in osteoporosis, it is established osteoporosis, there is also sarcopenia exists. And this sarcopenia is basically maybe the result of the fall, recurrent fall. And that fall can lead to the production of the fragility fracture. And there are some studies.
Yeah.
Yes, that is, some studies already shown that vitamin D supplementation that not only strengthens the bone itself, but it also increases the contractility of the muscles. So if we utilize that function of that vitamin D, which increases the contractility of the muscles with the help of some physiotherapeutic measures for strengthening their muscle exercises, especially the plyometric exercises, balance forming exercises, that not only increases the strength of the bone, but also that increases the balance of the person to prevent the fall during this, even in a slippery surface. That is most important.
That's very nice. Thank you very much. I think we are going to close because of short of time. Can I just hand over now to the organizer? Mr. Ashok, yes, please. Thank you very much, Mr. Ashok Singh.
Thank you, sir. Thanks a lot. And I will request Professor Jargar to kindly announce the Indrabadan Ambalal Modi Award and conclude this, so that I can give vote of thanks. Over to Dr. Abdul Hamid Jargar.
It's a real pleasure we are coming to the fag end of the program and probably the most prestigious component of the program. The Indravadan Ambalal Modi Academic Excellence Award has been instituted in the memory of Shri Ambalal Modi to honor and encourage the brilliant postgraduate students for their brilliance that they have shown in their academics during their postgraduate studies. Ladies and gentlemen, we present you the awardee. Please go ahead.
The Indravadan Ambalal Modi Academic Excellence Awards have been instituted in the memory of Sri I.A. Modi to honor and encourage bright medical students who have shown excellent and consistent academic performance in their postgraduate medical studies. This year, the awards in the field of medicine go to Dr. Patel Ravi Hasmukh Bhai from Surat Municipal College of Medical Education and Research, Surat. Dr. Patel Tirthesh Dashrath Bhai from Srimati NHL Municipal Medical College, Ahmedabad. Dr. Ravi Shankar Shukla from Pandit JNM Medical College, Raipur. Dr. Saksham Pandey from GSVM Medical College, Kanpur. Dr. Sandesh Malu from Government Medical College, Aurangabad. Dr. Saurav Paul from Government Medical College, Bhavnagar. Dr. Sonia Goyal from Rohilkhand Medical College and Hospital, Bareilly. Dr. Sweta Rajkumar from Government Medical College, Surat. Dr. Tamboli Krinal Rajesh Bhai from Government Medical College, Aurangabad. Dr. Vipin Singh from SN Medical College, Agra. And Dr. Vorungati Nitin from Kakatiya Medical College, Warangal. Congratulations to all the winners.
Thank you. On behalf of Cadila Pharmaceuticals, I thank you all for taking time out of your busy schedule and become part of this iamicon 2021. Your presence certainly has enriched and elevated the stature of this conclave. I thank our chairperson, Jargar sir, for chairing the session. So thank you very much, sir. I am really thankful to Dr. Rishi Shukla for moderating the first show. And I'm extremely thankful to Dr. Arpandev Bhattacharya for moderating the session, sir. Thanks a lot, sir, for taking precious time out of your busy schedule. I know that you have to attend one more meeting, which is extremely important. And I thank you all the panelists, especially to special thanks to Dr. Ramesh Goyal, Dr. Shubodh Banjal, Dr. Shaket Khan, Dr. Amitabh Shur, Dr. A.K. Paul, and Dr. Ajat Agarwal. So it has been a fantastic academic fellowship from, I think, a nice participation from each one of you. I also thank the entire audience, which has been listening to our conversation for last 2 hours. I thank the iamicon team for support, which has been happily rendered to make this program absolutely successful. I thank all my fellow Cadilians for working throughout the day this program and made this program a great success. Our founder chairperson, Sri I.A. Modi, said that true celebration of research lies as much in invention as in making the medicine affordable to the last man in the society. The concept, the core values has been Sarvodaya through Antodaya. In fact, iamicon celebrates that thought. We would love to take this journey of innovation further in the coming weekends to meet you again. On the other note, I once again convey my thanks to all of you. And I request you, sincerely request you, actually to visit our exhibition area and please try your hand at the informative medical trivia. So please do visit our stalls, which are virtual stalls, which are waiting for you. Thank you. Once again, thank you to each one of you. Sir, thank you very much. Thanks a lot.
Yeah.
Wonderful
So
session.
Ashokji, with your permission, we have a small thank you AV as well. And I'll request the technical team to play it, please.